All right, good evening, everybody. I'd like to call the April 10th Community Mental Health Program and Budget Committee to order. Start out with our mission statement: Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence. Having said that, I'd like to welcome our newest members. We have Ryan Fantuzzi, Megan Burke, and Dana Freers, and Linda was reappointed. You all know her very well, so I just wanted to welcome you all, and here we go. First up, I will take a motion to adopt the agenda. Motion from Chris, support from Linda. All in favor signify by saying aye. Aye. All opposed? The agenda is adopted. Next, we have hearing of the public. Anybody from the public wishing to speak? You have 5 minutes. Give us your name and address. Going once, going twice. All right, we will close hearing of the public. Next is item 4A, a request to approve. Authorize Office of Substance Abuse to issue a RFP, request for proposals for select services, outpatient, intensive outpatient, drug-free and medication-assisted treatment, and adolescent, residential, and subacute detoxification. I feel like every time you come up here, I have 50 things to say. Well, Randy, go ahead.
I appreciate that you did that, but I don't have to do it.
No problem.
Just briefly, you know that our entire system of care has been designed based on a competitive bid process. And traditionally every 3 years or so, we would issue an RFP for all of our services, and then as a result of that, we go through a vetting process and then come and bring recommendations for contracts that, even though they're renewed every year, they're guaranteed a contract unless we have some issues. So we've done the full RFP. The last time we did that was in 2015. When I say that, that means all services that we offer, which has gotten to be fairly unwieldy to do. So we went from that. We've done 2 other RFPs that are more selective. Back in 2016, we did an RFP for residential services, detox services, and MAT services. And then after that, we also did one for recovery home issues. What we're looking to do now is we're not going to do a full service RFP. There's a lot of reasons we don't really need to do that. All of our providers have been in the system for quite a while. We audit them on a regular basis. We know where they're at. We really don't need to make them go through that, especially having all of the STR dollars and SOR dollars that came down. They've all had to scramble to get new services up and running. So what we're looking at are areas of need, where we have these are the areas that we've identified as areas of need: outpatient, intensive outpatient. Those are 2 areas that we are almost getting waiting lists for, so we want to make sure we have a few more that we can add to our system. We want to do, we're including MAT with this, but not really expecting too much, because the MAT we went through it before and we didn't really get what we needed, but so we're putting that in there to see if we can get some more. Also, the adolescent residential and detox services. We have a contract right now with a program called Holy Cross up in Saginaw. And it's been a good provider for most of the time that they've had it, but they've just ceased doing adolescent residential services. So we're looking at we were looking at checking some other ones out. Back when we contracted with them, they were the only adolescent provider in the state for residential and detox. So now we want to try to expand that. And that's about it, I think.
Perfect. I will take a motion to approve, and then if there's any questions or comments, we can follow up with that. Nick, were you making the motion, or were you asking a question? Okay. Motion by Nick, support from Joan. Any questions or comments on this item? Kathy?
Mr. Chair, I just encourage you to encourage the speakers to, instead of using all the acronyms, just we have some new members here, so thank you.
Okay. You just doubled the size of my speeches.
And I guess if you want to introduce
I don't
yourself.
know what they all mean either. So.
I do most.
And I guess when you come up, if you'd like to introduce yourself to the new board members, so
Okay.
your name and your
I've met
position.
them all, Megan and Ryan and Dana. Yes, hi, again.
All right, seeing no questions or comments, we have a motion and support. All in favor signify by saying aye.
Aye.
All opposed? Motion passes. You don't have the second one, do you? Yeah, you do. All right,
got
item
three.
B.
My lucky day. You're yours.
Approval of Meridian Health Services request for a rate increase for subacute detoxification and residential treatment resulting from increased staffing requirements by Michigan Licensing and Regulatory Affairs. I'll take a motion to approve.
I'll make that motion, discussion.
Motion from Joan, support from Selena. Randy, go ahead and then we'll go
Okay.
to comments.
First thing I want to say, because I always forget to say this, but the Oversight Policy Board has vetted this already, and they have already, they're recommending approval of this. It's an integral relationship. So basically, we have Rick Page here today. He's the CEO for Meridian. So I'm going to ask him to come up here in a minute and talk a little bit more about what it is that we're doing. It's a significant increase. It's also one that I think is, we're going to see more of those requests coming because the state last December changed some of the licensing rules. And if you've read this, you have kind of a sense of what has happened, is they're requiring 24-hour medical staff at all residential and detox programs, which has not been what was required in the past. In our residential programs, people often say, they talk in terms of inpatient. We don't do inpatient. We've never been able to do inpatient. We haven't been able to, it was disallowed by the state. So it's always residential. When we talk residential, we talk detox. The change in Lara's change into the actual rules that came into play has increased the costs of doing business, and not a cost that they anticipated when they started at the beginning of this fiscal year. And I also had to stay out front that Meridian Health is one of our better providers and has been very good. It's been a great contract with us. So with that, I think I'll let Rick take over and kind of walk you through a little bit what his request is.
Thank you, Randy, and thank you, everybody, for hearing us out on this. As Randy said, I'm the CEO of Meridian Health Services. We've been doing business for over 50 years in the substance use area, and we provide services to 8 out of the 10 PIHPs. Our 3 biggest PIHPs are Macomb County, Oakland Community Health Network, Region 10. We've asked for this price increase of all 3 of those PIHPs and one other, who is the 4th one. Oakland County Oakland Community Health Network has told us that they will agree to these increases by email, and Southwest SWIMBA, we call them, has told us they will agree to the detox. They're still working internally on the request as it pertains to the residential piece, and Region 10, it's in their financial section, and they're working on it right now. As Randy correctly pointed out, with respect to subacute detox, and for those that are new, we provide 3 essential services, well, actually 4 now, to Macomb Community Mental Health. The first is subacute detox. The second is residential treatment. Subacute detox is a 3 to 5 day program, depending on the drug that you're on and the protocol that applies. The residential program is anywhere from 7 days to 28 days, depending on the individualized treatment plan that's developed at the time the client is admitted. We then also offer MAT treatment. For Macomb County, we currently only offer Vivitrol and Suboxone. Although I've talked to Randy about the opportunity of doing methadone. We just started a brand new methadone program in Oakland County. And then we offer general outpatient. So those are the 4 general services that we provide to Macomb County. The services that we're seeking the rate increases on right now are for subacute detox and for residential. And as it relates to the subacute detox, the LARA rules comprise the biggest component of that. The one requirement is that you have at least a limited practice nurse on site 24/7, 365. We've vigorously argued against this requirement. It's not necessary. This is not inpatient, but nonetheless, it is now the law. And the next requirement is that a doctor perform a physical examination of the client upon admission. And our current contracts range from anywhere from 24 hours to 36 hours that we can do that physical examination. It doesn't have to be upon admission, which allowed a more orderly scheduling of the intakes and a more limited schedule of the doctor. But as a result of that, we now have to expand the doctor's hours and have hired additional medical doctor and a physician's assistant to accommodate this. We broke down the costs for those two provisions. The LPN requirement, the cost to us is $507,000 annually, plus the fringe benefits is another $50,000. The other basis for the subacute detoxification services increase is we've had a 16% increase in medical supply costs over the course of the contract. The contract, as Randy said, was awarded in 2016. There were no provisions in that contract for any kind of adjustments as business expenses go up from one year to another. So we're actually entering into the fourth year on this contract with no increase at all. And so that's another basis for it. And then the other basis is when we originally got the contract as it related to subacute detox, at that time, the cost of those services were actually higher than what the contract amount was. But we took it as what some would call a loss leader, because on the residential side, we could make up for that. And so we can't do that anymore on either side. Last year we had, and we submitted this as part of it, we had a $400,000 operating loss last year, and for the first 5 months of this year, we're operating under an operating loss. And that includes the increased staffing that we started already because of the layer requirements. For residential treatment services, the costs there, mainly the cost increase request there is really about a 10% increase. And as I said, with this contract having been awarded 4 years ago with no increases at all, 10% is pretty reasonable under any circumstances. But because of the expansion of Medicaid in Michigan, the increased demand for behavioral health social services, our clinical staff costs have gone up 24%. And even at that rate that we're currently paying, we're having a hard time attracting clinical staff from folks like you guys, among others. And so we're going to have to further enhance that package. So those are the reasons for the requested rate increase. I think I've covered everything from my perspective. What questions may I answer?
Nick?
Yeah, Rick, you made a pretty good case for a rate increase, but what I can't find in here is what rate increase you're asking for.
Oh, it was part of our original submission. So for subacute detox, we're looking for a daily rate of $374 per day.
What is it now?
Right now, it is $230 per day.
So you're asking to go from 230 to
$374.
374 on the one side, and on the other side?
From 168 to 186. Is that right?
86. And can you?
165 to 186.
155?
Right.
165 to 186,
To
correct.
186. And can you tell me what the LPN's salary levels range?
So my HR department put the numbers together. I can't recall off the top of my head what we did. What I can tell you is the 507 is the salary for all of them, plus
How
the fringe.
many are there
So there would be 7 at that.
at 507?
Yep, plus the fringe benefits of 50,000.
That's for all of the employees or for the breakdown we have above? You have a breakdown above or below me? No, I guess it's above. That indicates,
Oh, actually, yeah. So it says right here, LARA rule change, 10 full-time LPNs. So it's 10 LPNs. And it's 507,002 and 50,000 with the fringes. So it's 557,002.
That's the increase?
That's the increase. So that's
the
the
10.
effect of the layer.
So
rule.
it's a $55,000 increase, but that's not my question.
Oh, I'm sorry.
Because one of the things, I mean, for instance, you gave me the information I wanted on the total per diem, and this is split up according to salary wages, at least according to the chart that was in our packet, indicates that I guess I'm not sure, Andy, what you intended here, but it looks like it says we're paying 0.8% for your salary, 10%, 0.1% for the chief operating officer, and then 100% for a program supervisor, peer volunteer, a peer recovery coach, two peer recovery coaches. But
I'm not sure. May I see what, I'm not sure which document that you're looking at.
it's the
Oh, it's-
care. Oh, I'm sorry. I'm on the next. Sorry, I went too far down. I went to the next one. Sorry about that. I apologize.
That's okay.
Okay, don't pay any
I'm
attention to
glad
that.
I'm
But
glad
what
I
I
wasn't-
am asking you is what the salary ranges are for your LPNs.
So I don't know the exact number.
Round
I
numbers.
think it's about 36,000 per, 32 to 36,000 per. And then
32, I assume there's a range based on
Yeah.
how long they've been with
I
you.
think it's 32 to 36 for salary, and then the 507 also includes the increased hours for the doctor.
Right.
Increased hours for the doctor.
And how much is your lowest paid employee
Our
make
lowest
per
well,
hour?
Our lowest paid employee, and this is another issue I talked with Randy about, right now is $11 per hour is our lowest paid employee, and we can't compete at that number either.
Yeah, I mean, that's part of the problem. We used to have a requirement where the state prohibited us from having a requirement of a living wage.
I know.
But that doesn't mean we need to contract with people who don't pay living
Right. The
wage.
Taco Bell down the street pays $15 an hour.
And so if you get these rate increases, do you intend to adjust those
Absolutely.
in
That's one
order
of the
to
reasons we need
attract
them.
more?
Yep.
And where do you think you're going to be able to go?
Well, so the starting wage, I told my HR guy, let's update our, we call them milieu technicians. They're the people that walk the floors. Let's update it to $12 an hour, see if we attract anybody. If we don't, we're gonna go up to 13 until we can start attracting qualified applicants.
Okay. And the LPNs are at 32 to 36.
Yep,
That's a year, 32,000 to
correct.
36.
that's
With plus benefits.
plus benefits. Yep.
Plus benefits, yeah. Okay, thank you.
Any other questions?
Ryan?
What's the length of this contract?
So it was originally for a 3-year term, and now it automatically renews year over year, unless there's an issue between us and Macosa.
This one runs through September
Okay.
of 2019.
And Randy, what is excuse me for my ignorance, the Oversight Policy Board?
The Oversight Policy Board is secondary board that was replaced just for substance abuse. And it was put into place to make sure that dollars were not stolen from one way or the other. That's a crude way of saying it, but basically keeping things separate. The Oversight Policy Board is responsible for making decisions about local funding. So we have PA2, we get some funding from the county that's unspecified. Those are the dollars that they make decisions. So we take it to them. We don't bring them back to you for decisions, although we usually bring them back for review and file so you know what's going on. So
That answers my question. Thank you.
Any other questions?
Joan?
Yep.
This is through the chair to our director, Randy.
Yeah.
Is this in your budget? Do you
Yes.
have the money to
Yes,
cover this?
All of the costs we're talking about, we have a fee-for-service agreement with Meridian Health, and so it's Medicaid and it's Healthy Michigan dollars that pay for it. And the way it's gonna hit this year it won't be as impactful because it's got a half a year left. Next year is when the full impact's going to hit.
Well, you won't be coming back to us for money, will you? I mean, you get
No,
your,
if you make the decision today, by the next board meeting, if you make that decision, then that will be the new rate that they will be operating on. We shouldn't have to come back asking for additional money.
okay, thank you.
Linda?
To Randy, we have other providers who do the same services, right? The subacute
Yeah.
and the,
Similar, yeah.
so aren't they gonna be at the May meeting? So this contract, we have to consider, this is more expensive than what we're seeing tonight. What would preclude them from saying, well, Laura increased us too? I mean, has,
Good question. We also asked at the Oversight Policy Board meeting is what kind of precedent it's, and I can't tell you for sure, but I would guess some of the other residential detox providers will come and ask for an increase. But it may not be the same. You know, I say what we need to do is we just have to take it one at a time.
given that he has trouble getting quality workers at the wages that this contract allows or what he pays, do we want to be proactive and look at the other contracts and, do you want to, Randy? No. Rather than wait for them to, I mean, if they're being, we're underfunded by the state, and if they're being underfunded by us, that, rolls downwards.
Yeah, we meet on a regular basis with our directors of all of our providers, and that's something that can be broached at a meeting. Actually, I wouldn't do that. I do it one-on-one, one by one. And then, we could certainly do it. I was already gonna, next biggest one would be Sacred Heart, and I've heard that they're not gonna do it now, but they're gonna come back. Because it's a requirement, it increases costs. Unless you got a lot of extra money in your account, they're gonna be coming to us for that. We don't pay for these services directly. We pay for the services they provide. So they gotta come up with, their own costs. They have to, come up with the costs, their own budgets to pay for those. Our rate is built on the budget that they provide and the projected services. Did I say too much? Okay.
So the May meeting's going to be fun. Nick, go ahead.
Yeah, just a couple more questions as I'm going through this. As I look at this rate, you're talking something like a 62% increase on the subacute detox costs and about a 12% increase on the residential costs. Is that, what's the difference there? Is that because of additional personnel you'll be putting on, or is that?
Well, yeah, that's essentially the $550,000, $557,000 as a result of the LARA requirements. And then in addition to, the other costs of living increases that we've had to pay out to our staff over the 4 years of this contract that we have not been able to recoup back because the contract doesn't have any kind of a provision in that for adjusting. And as Randy said, it was originally a 3-year contract, and then it just renewed in year 4.
No, I understand
So-
that, but I'm trying to wrap my head around why one of these is seeing a 62% increase, and the other column, the residential costs, the rates are seeing a 12%
Yeah, and
increase.
so I can tell you that the two main reasons for that are because of the LARA requirements, and when the contract was first let, our detox costs were already about $270, but the contract was only for $230, but we took it as a loss leader because we were also doing the residential services.
And you were
which were
making
subsidized.
money on the residential side that subsidized the subacute side?
Correct, which is no longer the case.
Which is no longer the case. Now, will this subsidize in reverse, or
No,
will
so
they be
the way
both
that
balanced?
we structured this, and when Andy's eyes, he put his eyes back in his head when he saw the increase, I explained to him, my goal here is to stop subsidizing one unit or another. We should be contracting for the actual cost of each unit. And they should be standalone, and from a financial perspective, and operate on their own. And so that's what the pricing is based on.
And Randy, going to Linda's question, because we have to think about the whole picture, about what percentage of these types of services does Meridian handle compared to our total population? Are they 50% of the book, 75%, 25, 2%?
I don't really know the answer to that, but if you want me to hazard a guess, I'm always willing to do that. But I would guess, I'm sorry, stand up. I would guess about 14%.
So it's a small percentage, it's not of the total that provide these services, relatively speaking. So we're
all of
talking
our
about,
services.
so what's the total cost of this adjustment approximately? Give me a ballpark figure.
For what we're paying, well, you know the rates,
Yeah.
and
The increase will cost you
it's
how?
gonna cost us probably total about $675,890.
So let's
in
say
a full year.
675,000, and if everybody else were to ask for it, you're talking about 5 or 6 times that amount, which is 3, 6 times 7. That's a lot of money, right? So
Well, it is a lot of money.
it's
That's why you
about
said
four-
my eyes
It's about
popped out of
4
my
million
head.
in terms of, if everybody asks for it, it's over 4 million, I think. 675,000 times
Well,
6.
I don't know that that would be accurate or not. That might be greater
Well, if
because,
all of the rates were the same for these services,
well, yeah, but they aren't,
but if they were,
yeah.
and I think Linda has a point, if we grant Meridian this rate increase, I mean, if I were providing similar services or the same services to you, I'd say, well, that's your rate increase with them. Why isn't it your rate for us? And so if they all ask for the same rate, we're talking something like $3 million, and I don't know if your budget can absorb
Yeah,
that.
well, I don't think, I mean, you could do that on the fly, but I don't think you can accurately predict what that's gonna be. Rates out there for residential services start at $68 a day for one of our providers. And a lot of the providers aren't even at this level that we currently have, so.
Well, why is that? I mean, what
Because we do a
is it
competitive
the
bid.
level of service?
They all do basic level of services, but they all do them differently. They all have different costs. If you go to a Salvation Army, Harbor Light, their costs are much lower than what these costs are. You go to
Because they
sheriff-
provide less service, or, I mean, are the results any different? Why wouldn't we be using if somebody can give us the same service for $75 a day rather than
I wouldn't equate, they're not the same service. you
Okay.
know, And the quality of the services vary.
The qualities vary.
Yes.
Is it different types of services, different results, different long-term results? I mean, what do you, if somebody comes to you and needs this service, how do you decide which of the providers you choose? I mean, we pay, on the mental health side, we pretty much pay the same price per service regardless of who the provider is.
Well, believe it or not, our system was based on, because we never had enough money to provide the services there.
Sure.
And so when we do the request for proposals, when they come in and people submit their proposals, we look at basic levels that they're providing. We looked at extra things, if they're women's specialties, if they're providing case management, when they start, in some cases it's having peers. The level, they all differ. And we're, if we did start saying, well, okay, let's get all the Salvation Army, we wouldn't have much of a system left. And if we tried to put everybody at the same level, if you wanna, we have every provider, I'm not gonna tell you which at this point, but every provider is different, and some providers are better than others. And usually we have to pay a little bit more for that, but yeah, they probably do get better. They're
Well,
better at,
I guess I'm confused.
so am I.
Because, well, that doesn't help my confusion.
No, but that's where we're going, I'm not sure.
But what I'm trying to figure out is, I assume what we try to do is match the consumer to the services they need.
We do.
And if there are different levels of service or different, it doesn't sound to me like there should be that huge of a difference in the quality of the service. There might be a difference in the type of service or the amount of service needed or the program needed.
Now, maybe quality probably isn't the right thing to say, but some are more responsive than others. Some are offering services, more services than others are. I think in this case, they have a very strong support staff in there and what they do. They're always willing to, when we want something new, they're willing to take it on. They took on the MAT program that he was just mentioned, which, we've been having a hard time getting providers for that. And yet that's an area that's one of the newer areas, but it's where we want to really push. I would like to have MAT services in every program, at least every outreach.
But do you pay for that separate, or is you pay for that? That's a separate rate?
Yeah, they're separate. It's a separate rate.
Yeah, okay.
The other thing is that we have a system of care. We've tried to make sure we had enough residential services in place, and I think we do now, and detox services in place. But it always comes down to when a client calls access, where do they want to go? And so
Where does who want to go?
the client,
Oh,
or potential client, when
consumer.
they come in and they're asking for services, they always get first choice where they want to go. And some are, get more than others. And because of the type of services they have, or maybe it's just reputation, but. All right, I don't know if I can get to where you want me to go, but.
Probably not at that point, but what I would like you to do before the full board meeting is if you could get me the following information, a more definitive percentage that Meridian provides of these services of the total population, and what the range, and what the cost would be if everybody was being paid. We got the same percentage increase. Let's do it that way if there's such a difference in the level of current services. Okay, thank you, Randy.
Any other, Ryan?
I have a simple math question. Is it, according to my math, moving from 230 to 374 for the subacute detox costs, is that the right number, 230 to 374?
Yeah. Mm-hmm.
That appears to be a 62% increase, is that right?
I think that's what,
Okay, but when I look at the cost for Lara, that only appears to be a 36% increase is due to Lara. So and I don't understand the basis for the 16% of supply cost, but I'm still confused about the math. What's your basis for the rest?
So as I said, there were two main reasons for that very large increase. The one was the LARA, and the other was the fact that when the contract was originally awarded, we were already doing it at a loss. So when the contract was awarded at 230, it was already a number that was lower than our actual cost.
But you make a profit on the residential services, correct?
Yes.
Okay.
It's very thin right now, but yes,
And it's 165 to 186, is that right?
correct.
Okay. And then according to my math, the percentage that's due to Lara is a 3.6%, yet the total cost of the increase is 12%. Does that sound right?
Now, there's as it relates to the residential, none of those changes, none of the increase relates to anything with Lara.
Okay. Then what about the salary increases of the 138? What's that from?
It's just because of the increased demand for the behavioral health services, we have had to increase our clinical service pay structure in order to attract candidates.
Okay. Thank you.
Any other questions or comments? All right, I don't see any, so having.
Just one quick comment.
Real quick, you've had 15 minutes already.
I'm sorry. I'm going to move. What I'm about to say, I think you know. I mean, there's a lot of questions still in the math on this, and I'll get with Randy separately. I'm going to vote to move this to the full board, but that doesn't mean that I will be the yes vote at the full board. I want to hear some more information from Randy first.
Bring that
I'll
information
be
here.
here.
Perfect. Thank you, Nick. All right, we have a motion and support to move that to full board. All in favor signify by saying aye. Aye. All opposed? Motion passes.
Thank you all for your time.
Thank you. Next, we move on to item 4C, approve care of Southeastern Michigan's proposal to establish a recovery community and resource center. I'll take a motion to approve. Motion. Man, normally it's real quiet. Now everybody's throwing a motion by Selena, support from Lori. All right, Randy, go ahead.
Okay. What this request, and this again was vetted by the Oversight Policy Board, and we haven't determined yet if it's going to be, well, it might be a mixture of funding, so we're going to cover it. You know, it might either be PA2 or it might be BA2 and block grant dollars. So it doesn't matter. I'm bringing it to you for your decision anyways. This is a recovery center, community center. It's been an idea that's been in our system for about 7 or 8 years. We've been, you know, our system has moved more toward people in recovery, you know, the old Office of Recovery Oriented System of Care, we get more involved in that. There was a program within CARE that's called Project Vox, which is a recovery advocacy group that's been around since 2005. They, at this point, thought it would be a good idea to have some kind of a community center, resource center for people that are in recovery. It's kind of like Clubhouse in respect is what it is. This one's going to have a lot of services that are going to be built in, as well as a social piece of it. I think you'll find that, and I have Monique Stanton, who's our director of CARE. I think she's been here before, so most of you probably know her. They have done a lot of, spent a lot of time planning this, trying to find a space, getting input from the community, the recovery community, and she's going to walk through that. She's got a quick, presentation to make, and so I'm going to just step aside for this and let Monique do it. You can get me back whole next month.
Good evening. Thank you. Good evening. Thank you for having me out today. I am really excited to be able to share a little bit about our Recovery United project and specifically the center that we are planning on opening. Over the last few years, for those of you that aren't aware, CARE has significantly grown in terms of reach in the community, size, community impact. We've almost tripled in size, so we are literally bursting at the seams. So this proposal really fits two needs of our organization. One is to meet the growing needs in terms of the recovery community, offering new and enhanced services, but also creating a home base for our peer recovery coaches. We're very likely getting an additional grant through the Department of Labor, and with that addition, we'll have a little over 40 peer recovery coaches at CARE. So we have ballooned and grown pretty substantially. So our planning process in terms of over the last 2 years specifically, we have conducted a significant amount of work really engaging with the recovery community to determine what the needs were related to a recovery center. And so we did things like a community survey, we did some focus groups with individuals in the community, we conducted a best practice review looking at both local sites as well as national sites, and we toured local and national sites as well to get an idea of what other organizations were doing. Back in 2016, we actually wrote for a SAMHSA grant, that's the Federal Substance Abuse and Mental Health Services Administration. This past September in 2018, I received an email from them saying they wanted us to award us a grant from 2 years ago. I actually thought the first email was spam because I hadn't written a SAMHSA grant in 2 years. But lo and behold, that was actually very positive news. So we have secured a SAMHSA grant that is to help expand our peer recovery coach program as well as to provide a base of funding for the recovery center. So our tentative location is located on Garfield Road, just south of 14 miles, so it is close to a bus line. I say tentative because we are in the final stages of lease negotiation, and so there's just a couple final pieces that we need to do both with the city and the lease. But at this point, I don't see any barriers going forward, but it won't be final until things are signed on the line. So our project approach is we are designing the center and leading, and it is going to be led by individuals that are in recovery, meaning that the activities and services that we're providing are for people in recovery and help planned and facilitated by people in recovery. We have a very focused trauma-informed care approach. We were actually selected this year to be part of the National Behavioral Health Council's trauma learning community, and so we had a team that went to the National Council 2 weeks ago to participate in the first step for that process. So we're doing a deep dive in terms of our trauma-informed care work, and that piece is actually being paid for out of the SAMHSA grant. We're going to have an advisory council that includes members of the recovering community as well as active recipients of service to really provide direction and support for the center. And the focus is really on supporting recovery, resiliency, and self-sufficiency. So some of the types of services, we'll have a computer bank for job search, resume writing, benefit access. We'll do recreational activities, things like book clubs, movie nights, things that are really at that moment people are interested in, health and wellness activities. We are going to have some specific recovery focus groups targeted towards specific populations, including a men's group, women's group, and a group for the LGBT, lesbian, gay, bisexual, and transgender community. Smoking and vaping cessation sessions. It will be where our Project Vox, our recovery advocacy group, meets. We'll do different types of computer skill workshops. This isn't on the slide, but we did have some of our coaches talk about could we do a literacy group, because we do know we have many people that are engaged in our services that really have low literacy rates and need help learning how to read. Naloxone or Narcan training, legal workshops, meditation, volunteer training. There'll be a big significant piece of volunteer work. And then we right now at our main site act as a pickup and drop off site for both Meridian and Sacred Heart, other types of residential facilities that are really close. So vans will come and pick up people waiting to go to treatment. And so the recovery center will be a nice welcoming place for them. It's going to be staffed. We have a peer recovery program supervisor that will be leading. It'll be part of our program, our peer recovery department. It will be a home base for our peer recovery coaches. It will also be a home base for the individual placement support services. That's the employment program that was approved last month that we're getting ready to start. We'll have a peer volunteer coordinator that's a part of this that will be responsible for recruiting and training volunteers and then providing sort of front office support to the center. And then we'll have volunteers. They can be peers, family members, or different types of recovery allies. The evaluation, we'll have satisfaction surveys, we'll look at attendance, we'll specifically look at repeated attendance or people engaging in multiple types of activities. Where appropriate, we'll do pre and post test, and we'll do biannual focus groups that probably should actually say semi-annual because we're meeting at least twice a year. And then the operating budget for this particular initiative is $400,000. You can see that SAMHSA is providing just under $250,000 of support for the project, and we're requesting an additional almost $200,000 from Macomb County Office of Substance Abuse and the Community Mental Health Group. And so we did have this is a condensed version of the budget. This is the specific request related to MACOSA. We're looking at $117,000 in startup cost. The annual operating costs are just under $200,000. That's a $360,000 program total. We are projecting about $100,000 in unspent funds from our existing budgets for this year. You're probably saying, why do you have that much money that you're unspent? Just based on when contracts have started and the amount of time it takes to ramp up in terms of hiring. And so there's been some staff vacancies, and when you compile that all together, that equals about $100,000. So the actual request when we move those funds around is actually closer to about $216,000. So are there any questions?
I have one before we go around the table. So I'm looking, we'll start with this. The grant, how long is the grant for? When does it run out?
It's a 3-year grant.
What do we do when the 3 years is up?
So for the 3 years, that's when we continue to look for additional fundraising services. I mean, some of that is actually for staffing, so if we can't find additional funding to sustain that staff, then we'd have to look at potentially moving the staff to other positions. We'll also then be moving our other peer services, and so as we continue to grow, those space allocation costs get allocated across all the different budgets that we have related to peer services.
So, sorry, didn't mean to interrupt. So like the cost for renting of the building or however you're doing it after that 3-year period, if you get no other grants,
We'll have to absorb that in other
CARE will
budgets.
or Macosa will, or both?
Potentially both. I mean, they're one of our lead funders, but we also have funding from Community Corrections for our peer services. We have funding from the Michigan Health Endowment Fund, from the Detroit Wayne Mental Health Authority. And so there are other bases of funding for this particular project.
Okay, thank you.
You're
Kathy?
welcome.
Thank you, Mr. Chair. Thank you, Monique, for
Kathy.
being here. Sounds like a good program. It seems like peer supports seems to be very successful. What, the groups, the areas that you went to visit that already have that sort of thing, what kind of results are they seeing, and what do we hope to gain from this?
So what we saw from other sites, and what I'm really hoping to gain is that long-term support. Our services, the individuals that are engaged in services right now, are typically still engaged in treatment. And so right now you're working on, I need a job to pay my bills right this moment. The next step from that is really things like, what do I want to do long-term for my career? And so transitioning from that immediate crisis, I need to get my bills paid, to the next step. So financial literacy, financial stability support, ongoing support, so you're getting, you're able to be more self-sufficient. You're able to get a good living, decent wage in the community, that kind of work.
Okay, do we have a way of measuring?
So for the IPS program, there's a piece around the IPS services in terms of we look at the individual placement support program. That's the new employment program that we're doing. It was approved last month. There is a evaluation component in terms of wages. There's not an official notice to award, but the partnership through the Department of Labor and Michigan Works that looks at sort of those long-term employment benchmarks. So that's the kind of stuff that we're looking at trying to evaluate.
Okay. And what are the general hours of operation?
So it's going to be typical business hours and then some evenings. And so in the evenings, it'll be probably 2 to 3 days a week till 8 or 8:30.
Okay, and then my last question, are all the services going to be peer services, or would you be also perhaps contracting or asking for volunteers for like financial literacy?
Correct. It'll be so in the budget there's funds to pay for different types of contracts if it's something that we need to pay for. Some of the work will be facilitated by peers, and then when people are meeting with their peer recovery coach, our coaches meet with people at our main site. They meet with them out in the community. They meet with people in the homes, but they'll be meeting with them now in the recovery center. So
Okay.
did I answer your question?
Well, I guess.
Oh, and the role of volunteers. So the volunteers, they will be there to really help with answering phones, welcoming guests, doing different types of activities. So there will be the possibility for them, depending on what somebody's skill set, to facilitate some of the groups.
Okay, but you might hire, if there's a need for financial planning or something, you might hire someone to help people do budgets and stuff.
This is actually not in this particular budget or in this particular proposal, but we did secure a $25,000 grant from Fifth Third Bank to specifically pay for financial literacy support. So part of what our vision for this project is, some of our corporate donors, some of our corporate partners and our community support groups, they really want to invest. They're not necessarily going to pay for a peer recovery coach, but a special program or project at the recovery center they're really interested in funding. So that's part of the long-term sustainability plan.
Okay, thank you. Thank
You're
you,
welcome.
Mr. Chair.
Linda?
I really congratulate CARE for having the, going out of the state and looking for federal funds and bringing them to our community, and for the Macosa office for supporting this effort with this contract. I'm not seeing that, how long you said the SAMHSA is 3 years. How
3
long
years.
is the Macosa contract?
There.
Sorry, Randy.
That's Randy's question.
I guess 3 years, annually renewable. Now,
Okay.
you know, I think that's where we're at right now. I think when you ask those questions, when it comes to sustaining an effort after that, I will be looking closely. I suspect that Monique will come back to us to ask for funds, and if we have funds available and we're happy with where things are going, then we would look at continuing to fund them.
But you're writing this contract for 1 year, not 3?
We don't write any of our contracts for 3. They're all written for 1.
Oh.
It's the understanding that they have, you know, that they have a 3-year commitment, but every year we do an annual, unless we can switch it to longer than to get a 3-year contract. And like to get on the same cycle as on the mental health side of our end, but we're not there yet.
And I have one other comment. I love the program. Sometimes with public programs, there's no money for what people call frills. I was in an employment program with people who had to get up and take 3 buses to get to work, so you have to really get up on time, and we didn't have any money to buy alarm clocks. So, you know, we wrote for what people would call frills, an alarm clock, but it was really a necessity. So I see that you've built in so many things that promote what a recovering life looks like that aren't otherwise provided for with Medicaid and other funding. So it's a great resource. Thanks.
Thank you. And just to be clear, there are specific services that we're offering here. This is not just sort of a drop-in hangout type center. It's not a drop-in center. It is more structured than that. Now, people can stop in, but it's not a general hangout. I'd say.
Any other questions or comments? Nick? Nick, hit your microphone.
A couple of quick questions. You said this is on a bus route, your proposed site?
It's near the 14-mile bus. So if you're familiar with the Fraser area, if you remember where the Anytime Fitness and the dance studio was, it's in that particular building. And there's a 14-mile bus that stops right at 14 in Garfield. So we're a few blocks south of the bus.
A few being
I think it's about 2 or 3.
2 or 3 blocks?
Yeah,
Okay.
it's not like a mile or something.
It's not a long distance.
Right. So it's actually going to
near
be
a bus route.
It's
Okay.
going to be much more accessible than what our existing location is because we're not
And
on a bus
what's your
route
target population for this?
there. Individuals that are in recovery or seeking recovery.
For substance abuse?
For
or
substance
beyond?
use, right.
Okay, seeking substance abuse. And that fits with the OSAS priority list, Randy?
Yes, it
Okay.
is.
The targeted population. And the
Actually,
advice,
it was one of the things they listed on the list of SOAR activities that people could sign up for.
okay. And the advisory group, I assume, also,
Pardon? Oh, yes, they did.
they did too as well. What is the staff level of payment for your lowest paid staff?
Our lowest paid staff person is $13 an hour, which that is for our summer camp workers. So these are typically people that are working like a 2-week summer camp for us. They're mostly college students that are working. Our lowest paid ongoing full-time support staff is $14 an hour. That's for our front office staff. We just did a big adjustment about a week or 2 ago in terms of adjusting their rate, which is, again, not a great rate. And then our lowest paid peer recovery coach staff, our peer recovery coaches start at about $15.38 a year, which equals about $30,000 a year. Right. All of our full-time staff that work over 30 hours a week, get full-time benefits. I will say, as a provider, we need to do more as a system as a whole to boost up our rates of pay for the people that are working with us. So.
And are those dollars with or without benefits?
Well, the camp workers, because those are part-time summer
Part-time,
jobs, they have no
they're
benefits.
without benefits.
But the support staff and our peer recovery coaches, we pay full benefits for the staff. So in our peer system, one of our values is diversity and inclusion, and we really believe that our peer coaches are like other staff, so they are entitled to our full benefit package, our paid time off, all the same things that any other care staff person would have.
Very good. Randy, you do have the available funds within?
Yes, we do.
And how is this a grant program or is this a payment on referral? How are we paying the 100 and some odd,
It'll be
200,000.
rolled into their usual contract as a separate activity. And so we will pay, we'll be using PA $2 pretty much to pay for that, which are local dollars.
okay, but I'm asking you is, are we paying them $200,000 or are we paying them on a number of
Oh.
referrals basis?
Well, our contract with them is what we used to call the old staffing grants. So we pay for the hours. It's not like, it's not based on services, although we have output requirements they have to meet each year.
So it's essentially a grant?
Yeah, okay,
That's all I was asking. Thank you.
okay.
Dana?
Thank you. I don't have any questions. I just wanted to say congratulations. When I read about this, I thought it sounded like a fantastic program. I do a lot of work with people who are substance abusers, and I think this would be fantastic. So congratulations to you, and I think it has the potential to really be something great, and it sounds like it's going to be.
Great, thank you.
Before I call on Joan, she's going to say, if it doesn't work out in Fraser, go to Warren. Joan, go ahead.
That's for sure.
We looked, we looked.
Did you look at
We
Warren?
did, yeah. I will say that was one of the hardest things, was finding a big enough building that was on a bus line that had enough parking, is almost impossible.
Through the chair, to Sandy, who's this oversight committee? I mean, you keep talking about,
The oversight policy
yeah, the
committee
oversight policy.
was-
Who is it?
Used to be our advisory council. You remember, we already subject to
Yeah.
this advisory council, but when they, what year was it, 2012, when they changed our whole system, they required that every PIHP have its own board for local funding. So now we have a board for local funding. They make the decisions, but they're also an advisory committee, so they're the ones that make the recommendations to you. But they can make, if we're just using PA $2 on something, they make the decisions. You don't make those decisions as a board of CMH.
Okay, is that the one that Commissioner Bush serves on?
No, Brian is the representative. Brian and
Yeah, Chris is also.
Okay. And then I want to ask Monique, where is this facility located from your business now?
It's really close. So we're right now located at Masonic and Utica, and so this is at Garfield and 14 Mile.
I know the area.
So it's really close.
Okay, thank you. Thank you, Mr. Chair.
Any other questions or comments? All right, seeing none, we have a motion and support. All in favor signify by saying aye. Aye. All opposed? Motion passes. Thanks, Monique. Keep up the good work. Thanks, Randy. Next is item 4D, approval for the Procurement Review Committee's recommendation to offer a Medicaid and non-Medicaid billing verification audit contract to Experis. I'll take a motion to approve, and then we can discuss.
So moved.
Motion from Kathy, support from Joan. You're up.
Good evening. I apologize for all the coughing. So this is our medication verification audit. That's a requirement for the PIHP. This is a renewal. We did an RFP. We had our submissions, and this is the recommendation from the procurement committee to you of the provider that we would like to go with. If there's any questions about the provider or the process, I can answer those.
Ryan?
How many proposals did you receive?
We received 2.
Okay. And why did you make this decision on this particular proposal?
We have a scoring grid that we go through, and so, excuse me, we rank them all on certain points. So we're ranking them on the cost, the quality, the staffing that they'll utilize, the professionalism of the submission, and the procurement committee is made up of representation from each division in the county. So we get a full gamut, a full perspective of that, and this provider scored higher.
Any other questions or comments? All right, seeing none, we have a motion and support. All in favor signify by saying aye. Aye. All opposed? Motion passes.
Thank you.
Thank you. Next is item 4E, approval of amendment number 3 between MDHHS and PIHP Macomb County CMH for the Medicaid Managed Specialty Supports and Services Concurrent 1915 BC waiver programs, the Healthy Michigan program, and Substance Use Disorder Community Grant Program. I'm done. I'll take a motion to approve. Motion from Lori, support from Selena. Any comments, questions, or discussion on this item? Kathy?
Yes, I would like an explanation of why we were asked to do this and what it would mean for the benefit of the new people and for those of us who still have no clue what this means. Thank you.
I'll turn it over to Dave.
I think Randy has all the information on this one.
Sorry, wasn't listening.
Randy's board approved this. No. What this was an expected kind of late-term third amendment to our current fiscal year contract, and this is specific to a direct care wage pass-through. Last year, there was a 50-cent per hour pass-through. This year, the state is putting money into the PIHP system for a 25-cent per hour. Because of the logistics involved in looking at these rates, developing the rates, informing providers, making the changes in our billing system to allow providers to bill at the new rates, the providers were informed to please hold off billing, submitting any claims, until the 15th of this month. The request is from the state that it be signed and returned to them by the 19th, which is before our next full board. So in your packet as a handout, you have our new adjusted rates at the, as a result of the 25-cent per hour increase. I would need to sign the third amendment and return that to the state by the 19th of this month.
Linda?
When we had the discussion on this at the last meeting, members gave you a list of questions for you to get answers from. Is this that contract? Why we had to do it? Who else uses it?
No, that was the MCG
Oh,
contract.
this isn't that. Okay.
That'll be at the full board.
That's at full board. Okay. Thanks.
So,
Nick?
so you have to sign this before the board meeting? I mean, we're a committee, we can recommend it to the full board.
I would need approval to sign and submit to the department by the 19th of this month.
And is this one of the contracts that requires sign off from the county exec? I believe all contracts do.
Yeah, I believe it goes to them after I sign as well.
Well, it has to go to them before you sign it.
Yes,
Has the county exec signed off on it? Do you-
not yet. We just got these rates. They're hot off the presses.
When did we receive the request for the third amendment from the department?
Just before we were meeting. It was last week with the very short turnaround time.
Yeah.
It was after full board and before today.
Right. And it's very specific. It's just to the 25-cent direct care wage increase.
Great.
Any other questions or comments? I know at the Board of Commissioners, we have a bypass process where we can prove things like this. I honestly don't know if we have that process here. So that he can sign it in time and have it done before full board.
Well, just for the
Nick?
benefit, the reason I asked the question about the county exec, just for the benefit of the new members, we had a ruling, as you know, that said if the county exec didn't sign it and we signed it, that opens up personal liability for board members and for the executive director. So we don't send in anything with the signature until the county exec has signed it, because otherwise, as I said, it makes us each board member and the county and the executive director personally liable, which is not a good thing, shall we say. I think we can all agree on that. So I don't know that the county exec needs needs to go to the county board of commissioners on something like this. I don't think so.
No, I'm just saying that there is a process with the Board of Commissioners. I don't know if that process exists with this body to
We don't-
where we can do this before full board, since we are a committee of the whole as it is.
We're a committee of the whole, and I don't think we do have such a process. However, I think we can, I don't know what we can do. I mean, we can, if we adopt it and recommend to the full board approval, David can, I think, rely on that. If enough of us say he can rely on that we will approve it at the full board meeting. It puts us in a pretty difficult, it puts him in a very difficult position. You may want to talk to the state and say, when is our next board meeting?
The 24th,
24th, and this is due by
the 19th.
the 19th.
I can talk to Corp Counsel and see what's in the bylaws. Typically,
I don't ever, Kathy might remember better than I, but I don't remember anything in our rules that allows the committee to give you that authority. We can recommend to the full board that you be given that authority. You may talk with the department about being able to wait until the full board authorizes you, which would probably be the easier. We're only talking about 5 days, and it's retroactive, and they didn't give you enough notice. But, you know, unless you know something, Kathy, that I don't remember or somebody else does.
Kathy, go ahead.
Yeah, there's that executive committee has some privileges, but I'm not sure if that's one of them. We'll just have to try to do the best we can, and then perhaps adopt something similar to that, so in case there are some future things like this. It seems, I don't always like doing things at the last minute. I know you don't at all.
Yeah.
But there are times it's beyond our control. They gave us these unreasonable dates, and
And as the new members, for the sake of the new members particularly, we really don't have a lot of choice in these. The contract between the PIHP and the state is negotiated statewide by the state association. We're involved in that, David's involved in that, but essentially when the state says, here's the contract, we either sign it or we cease to operate. So they cease to pay us to operate. They're 90% of the money now. So we really don't have much choice in the matter, and we're going to end up approving it. I'm just concerned about putting people in a difficult position. I don't have any problems with this one, but.
I haven't, there's an,
Kathy?
on Monday, April 15, we do have that personnel meeting. So perhaps we could call a special full board meeting for that same morning to ratify if we needed to do something. If we don't have, that would, right? Because you have to have it to them on the 16th? The 19th. So we could perhaps do that. Have a real quick one. With that one item, right?
Okay, we can, yeah, we have a motion and support to approve this, and it will either be at a full board meeting on the 15th, or Dave can talk to Corp Counsel.
or the department.
Or the department to, yeah. All right, all in favor signify by saying aye. Aye, all opposed, motion passes. Looks like we need to come up with a process for that. Item 5 is a receive and file quarterly report for the AFIA data project. I'll take a motion to receive and file the report. Motion from Nick, support from Chris. Dave, did you want to speak to this at all? Jim?
That one's mine.
Perfect.
Thank you. This is an update on our FIA contract, which for the new members, this is a contract to assist us with our data collection, presentation, and reporting processes through a company called AFIA, which is a technology company that's based out of Ann Arbor. They work with other PIHPs in the state to provide them with similar services. And what they're doing for us is basically building us a data warehouse where we can go in and online extract data and pull reports that allow us to more quickly and more efficiently manage the things that we have going on a day-to-day basis, provide reports in terms of inpatient hospitalization, length of stay, those type of factors, and that carries across our system, and as we continue to build it, we'll have more and more elements that are incorporated into the data warehouse, which will give us more and more management tools to work with. So the board approved this contract in May of last year, or maybe it was June of last year, and we committed to bringing back a quarterly report. We had this prepared for a couple of meetings now, but because of our agendas over the last couple of meetings, it's kind of been delayed, and so this report was updated to cover Q2 and parts of Q3. So we'll be reporting on successes and information we've learned as part of this project for that time frame. If you go to slide 4, what we're looking at here are, as I said, data from both quarters 2 and some from Q3. The project in total includes the data warehouse and reporting program, as we talked about, but also a subject matter expertise, SME piece of the project, where we have a consultant that's working with us to help us design new processes, new workflows, and making sense of the data that we're getting from the data warehouse, so we can look at the data and say, okay, from what we're seeing here, what is the best way to proceed in terms of the structure of our program and the processes that we have in place, and they can provide suggestions to us and recommendations in terms of how to better, more efficiently manage the services that we're providing. On page 5, slide 5, the second quarter of the project, this was out of the original contract. By the second quarter of the project, AFIA estimates the total fees will accumulate to approximately $178,000. As of this point, or the point of the report, we're at $115,000. So we're about $63,000 below our expenditure at this point in time. AFIA was also predicting we would have a number of quick win situations where we could identify areas where we were seeing a return on investment, and we'll go into that in a little bit more detail later on in the report here. By the third quarter of the project, the AFIA had estimated that the total fees would be about $284,000. The actual fees as of the end of February are $179,000, so we're about $105,000 below budget at this point in the project in terms of the quarterly reporting. They had predicted there would be some temporary plateauing of results, which we have seen as we're looking at the data warehouse results. We can see some areas where we had these quick, immediate impacts on having the data available, and then we've seen some variations in terms of that data and some of the reporting we're seeing. We had a slight increase in our inpatient hospitalization rate in November and December. Now, we don't know exactly the factors that influence that. There's some seasonal things that seem to go on with regard to inpatient hospitalization. What we will learn over time, having access to this data, is why some of those things are occurring. We'll be able to compare year over year and month over month for data that will give us the level of detail that will say, okay, we can expect a seasonal increase or a seasonal decrease related to what's going on and how much we can predict that we'll be spending in a certain time frame. So this should give us some better predictability in terms of our utilization and our potential costs related to services that we deliver. We are also working on migrating away from the Crystal Reports reporting platform, which is an obsolete platform, and the information that we used to get through individual reports through Crystal Reports will now be available through the data warehouse. That complete migration we've kind of put off into the fourth quarter, and so that's something that they're working on right now, and we'll be working over the remainder of this month and the remainder of next month in order to try to wrap that up before the end of the contract. But it's something that will allow us to be more efficient, and we won't have to rely on an outdated reporting platform in order to gather data about the services that we're delivering. In terms of the progress that we've been making on the hospital inpatient admissions and having better access to data related to that, the improvements that we had seen over the first couple of quarters are holding pretty steady. We have seen that our costs and our days approved overall for inpatient hospitalization have maintained and continue to go down and reflect fewer expenditures on the inpatient hospitalization side. Data is available for increased monitoring. Open Access uses the dashboard on a regular basis to monitor key metrics related to the provision of that service and the use of service codes, intake volume, and client disposition. And we have also seen in the inpatient area, we've been able to track that on a regular basis. A number of key element factors that we're using on a regular basis in management team meetings to make decisions about how we move forward in certain areas. Also, as part of the subject matter expertise piece, we are working with that consultant to help us design open access and streamline paperwork requirements, establish processes that make that a more efficient process. And we've got some information in here later on that talks about the UBHC, the open access versus the UBHC numbers and the difference that kind of input has made for us. Okay, on slide 8, highlighted impacts. You can see that on the left side of the slide, we're down about 6,400 inpatient days over the course of the year. And when you look at the graph, and actually if you look at the graph on the next page, the authorized hospital days, you can see how for the last number of years even, that level of utilization is all over the map. It's very inconsistent in terms of hospital days that are being authorized and what our expenditures are related to those hospital days. If you look at about the last quarter of that chart, you'll see that starts to stabilize. It goes down and starts to stabilize a little bit. So we think we're doing a better job in assessing a consumer's need for inpatient hospitalization, using diversions when it's appropriate, and in effect reducing our utilization of inpatient hospitalization. So that has dropped pretty dramatically, and it's stabilized some. So I think our decisions are getting more consistent around, does someone actually need inpatient hospitalization, and are there better ways to provide services to that consumer? Next page is specifically related to return on investment. If we look at what our inpatient hospitalization costs were for 17-18 as we wrapped up the fiscal year, we have a reduction of about $391,000 related to that. And if you look at the cost of the contract and the staff cost, we come up with a rough return on investment number of approximately 207%. So we've saved about $358,000 on inpatient hospitalization over the course of the fiscal year. Now we've taken that and said, we're not going to attribute all of that to the availability of data. Obviously, there are staff interventions and staff processes that are changing and attention to the needs of consumers. But we're recognizing that between the data availability and the staff interventions, we are seeing that kind of reduction in terms of our inpatient hospitalization at this point in time, and still trying to provide the appropriate level of care for the consumers. Slide 12. You'll see changes in our average length of stay. At one point, November 2017, we had hit a peak of length of stay of about 11.25 days for an inpatient stay. Now, our average length of stay is 8.66, and our length of stay for the month of March, which is not on here, so the month of March alone is 6.91. One of the things that the Access Center has put into place was anytime a consumer is in inpatient hospitalization for 6 days, they are able to pull the information from the data warehouse, identify specifically who the consumers are, and then they have a consultation with the Access Center psychiatrist. And they review the case, review the treatment that's going on in the hospital. And if there isn't any active ongoing treatment at the hospital, they recommend discharge, and they look at what are the most appropriate aftercare recommendations for a consumer at that point in time. And so we're able to move people into more treatment-oriented levels of care. If nothing's going on at the hospital, we want to get them into aftercare arrangements that can hopefully continue to facilitate their treatment. So again, you can see that graph has dropped pretty consistently, and that the length of stay has continued to go down from that peak of 11.25 several years ago. In terms of our open access process, we are working on open access, and basically that is the ability for somebody to walk into or be referred to any one of our three main clinics and receive an intake appointment as immediately as possible. That allows us to make more expedient recommendations for treatment and to get people into care much faster than if somebody is provided with an intake appointment a couple of weeks out after they have contacted the Access Center. Here they can come in and receive as immediate as possible treatment. One of the things that we're looking at through AFIA is the kind of service codes that are being provided as part of that open access project. And in this case, we took information that we also had available from the UBHC and compared what we were doing under UBHC and which we didn't like the way that was playing out, and what we're now currently doing as part of the open access program. And the areas that we are providing more services in now, as opposed to the UBHC, is the I have a very small print here, so I have to go to my larger. I have a copy here. Thanks. The codes that you're seeing, the T1017 is a case management code. That's happening 21% of the time at the Open Access Center. The H0038 is peer services, so we're providing quite a few peer services out of there. The 90791 is a psych eval happening out of Open Access. And then the H0031 is an assessment by a non-physician, which is actually the intake process. The X0995, which unfortunately is a fairly large bulk of the time here, is considered indirect time. And so that is something that we're trying to manage as well as to try to reduce the indirect time as much as possible. And part of the way we do that is to drive more volume to the centers. And we're having an advertising campaign that's beginning soon in order to highlight the availability of open access. And I know that staff is talking with folks around the community around the availability of open access in order to have as many people receive that service as possible. Okay, in terms of, again, success rate of the open access project versus the UBHC, one of the things we wanted to do is to have a metric that helps us measure the success of a program. So on the 14th slide, the lower graph line that you see there represented billable encounters, encounters that are reportable to the state for the UBHC. For the same time frame, October through February, the UBHC had reported almost $234,000 worth of reportable services. For the same period for open access, there's 375,000 in reportable encounters, which is about a 60% increase in reportable services over what was going on at the UBHC. So we wanted to put in place, as I said, a measure to be able to evaluate, are we generating enough revenue or enough billable encounters in order to make this a viable program? And we'll continue to watch that. This is an element we have on the open access dashboard, so we can keep track of that and making sure that we're providing as efficient a service as possible. As we reduce those indirect time codes that are being reported, that cost will improve even more. this next slide is related to some problems that we had identified as part of this project. One of the things that's interesting about the AFIA project is it's highlighting things that we're identifying within the system that we say, oh my goodness, that needs attention. And as that comes up, we're addressing those things, moving on, but we are continuing to be able to monitor areas that we know aren't operating as they should be. This is an example of that where as folks were coming into open access, one of the things that we identified is that the staff were doing a intake for consumers that were returning to service that was considered a annual intake. And so if somebody's doing an annual intake, there's not a disposition on that. And so therefore, there wasn't a clear recommendation from that intake about where the consumer would go next. So what we did was we were able to identify that the annual intake was being done versus a initial intake, even for a returning consumer. The initial intake does contain a disposition and allows us to move that consumer to the proper level of care. And in the absence of the data that says, well, okay, why are we having a problem in this area? This data was able to show us that, wait a minute, we're doing the wrong intake type here. We're not reporting the right intake and using the right form in order to allow us to have a disposition that allows us to move that consumer on to the next level of care. So it's identifying problems that we then recognize and are able to attend to. Actually, you know what? I described the problem on page 16 is the annual intake issue. The one on 15 is another problem identification area where we saw a drop off in intake volume from January to February. We looked for what the cause was, and it turned out to be that there were a number of unsigned documents that staff had not finalized that document by signing it, and therefore it wasn't reported as an encounter, so it didn't show up on the report. So again, another problem area that we identified as, this data looks funny, what's going on, what's the problem, and we're able to fix that. Okay, so now we can skip to 17. This is just basically a slide that refers back to the last report that we did, because the numbers tend to come in a little bit beyond the quarterly reporting. There's some adjustments in terms of numbers, and this just brought those numbers up to date with regard to where we're at related to the numbers that we reported during the first report. So CO and timeliness, we saw a slight change, and then also there's an ongoing data cleanup that's going on with regard to inpatient hospitalization, where we were allowing inpatient hospitals a year to submit claims, and we had a number of cases where there was no final disposition after a year, so we knew we weren't going to get any more claims on that would need to be paid, but we still had an open disposition in terms of the inpatient hospitalization. So we're going back and cleaning those data points up. Again, another area where we again highlighted that we were finding a number of unaccounted for open admissions, and as we dug further deeper into it, it was like, okay, we've got cases that have not been closed out. It means that the hospital has not submitted a discharge report to us and has not necessarily submitted a claim to us. So there's no finalization of that inpatient hospitalization, and so these were just kind of inpatient stays that were kind of hanging open. So we're able to clean that data up as we identified that and the consumers that were involved there. And so that data is being cleaned up. The number you see here right now is 349. It's much smaller now because we've made a concerted effort to try to clean that up and make sure that that data that was in there as a unfinished admission wasn't continuing to skew our data. Page 18, this we talked a little bit about this last time, discovering that there are claims that have not received the discharge continued stay review, and therefore we had an area where we were uncertain about whether those claims were eligible for payment if a discharge review had not been done. What we discovered was that there's two places where a discharge review could be entered. In one area, the claims edit did not touch that, and so if the discharge date was entered in the other area, the claim could still process. We've gone through and looked at that, and there were only a handful of claims where that was affected, and we've put edits in place now to clean that up and make sure that we're not paying for any claims that we don't have a discharge CSR on. We're also putting into place right now a 60-day claims edit so that any claim that does not have third-party involvement has to be submitted to us within 60 days. Otherwise, we'll be denying those claims. One of the big advantages of that for us, it will give us much more predictability in terms of our expense reporting, because previously there had been a limit of a year for submitting claims, and therefore, obviously, if those claims are coming in over the course of a year, that's going to skew your numbers for every quarter of that year, because they're going to come in for the full course of that year. Now, if we have them within 2 months, we'll be much more able to accurately predict our inpatient utilization, which turns out to be a major area of our expenditures. All right. Page 19. This was we reported on a pilot project that we were working on at the last report. One of the things that we had identified was that the length of stays for non-contract hospitals seemed to be shorter than contract hospitals. As we looked at it, we discovered that that really wasn't the case, that it was more staff variability than whether the call and request for admission was coming in via the electronic CON or a telephone call. It was more of a staff variability problem with regard to those issues. So we've done some training, and also the MCG criteria that we have coming in will standardize some of the criteria related to the assessment for inpatient hospitalization. So that should also allow us to standardize decision-making around hospitalizations and over various staff. So we'll be looking at kind of inter-rater reliability related to the staff that are making decisions related to inpatient hospitalization. All right, ongoing guidance from the AFIA subject matter experts. We have a couple of areas that AFIA is working with on related to the subject matter expertise. One is access processes. What kind of information are we currently collecting at the Access Center? Are there better ways, more efficient ways to establish a welcoming presence or welcoming attitude for folks that are coming into the system, and more efficiently move them from the screening eligibility process into care? Second area is open access. As we're building that program, what are the best ways to approach that? Again, what's data collection look like? What kind of forms are we filling out? What kind of documentation are we collecting? What kind of codes are we using as part of the open access process? And what's the most efficient way to handle that? So we have regular calls with the subject matter experts from AFIA related to the open access and access process, so we can make that as welcoming and as efficient as possible. We also have an expert that's working with us on the financial reporting, the FSR reports that are due to the state on a quarterly basis right now, and there's some discussion about them either going monthly or thirdly, so that we're going to have more financial status reporting done to the state level. So they're working with us to take some of our spreadsheet materials and automate some of the processes that are involved with that, so that we can have that data more frequently, more timely for submission to the state, as well as bringing more accurate and more timely reports to the board. All right. Next page, we're talking about workflow analysis and chart review. And one of the areas that we're looking at is recidivism. We're trying to bring the repeat use of inpatient hospitalization by consumers down, and make sure that somebody gets into the appropriate level of care post-admission, so that we can avoid a rehospitalization. We have a group of consumers that tend to cycle into inpatient hospitalization up to 8 or more times a year. And we want to be able to identify those people, make sure that we're able to provide them with services that make sense to them and engage them in services. Unfortunately, in a lot of cases, there's a substance abuse component there, and people are not willing to engage in services. So the ability to identify who those consumers are and to be able to provide more specialized services to those consumers so that we're engaging them, we're using motivational interviewing techniques to try to assist them in enhancing their interest in participating in treatment. And so we're trying a number of different things in order to kind of capture that recidivistic population so that we can reduce those ongoing cycling hospitalization costs. And then also looking at through the open access workflow analysis, looking at redundant documents that are being used in the intake process so we can reduce documentation time, inconsistent use of billing codes for services. I pulled a report earlier today where it showed that we have 256 available CPT codes, the billing codes that can be used as part of our service delivery. That's a lot of codes for people to keep track of in terms of what's the most appropriate code to be used when providing a service to a consumer. So we have better access to data now in terms of what services are being provided to consumers through the analysis of the CPT codes. And so we're able to look at that and say, okay, is this an appropriate code set to be delivered at this particular unit? How are those services being used? What are those services? We can generate those pie charts like we saw in Open Access and UBHC to really look at the service mix at any given unit to be able to say, yeah, this is what we should be providing out of here. And if we're seeing things that we shouldn't be seeing, be able to get the supervision in place that makes an impact on that. All right, areas that we're planning to look at through the next 6 weeks. Improving care management, access to care, adjusting workflows and responsibilities so that we can actively manage contact with clients from the initial time that they hit the access center or open access through aftercare services to ensure that people are receiving the level of care that they need throughout their stay with us, hopefully resulting in a discharge to a lesser level of care or to a maintenance level of care that allows us to have a back door to the system. So as people get better, they are able to move away from the system and come back quickly if they need to, still have that support available, but to be able to have basically a back door to our system so that people have a way that they can leave the system and still function adequately. We're also looking at provider management and improving provider compliance, creating tools for providers to effectively manage their client population, monitor their performance against contractual standards. We're looking right now at how do we roll some of this out to the provider network so they'll have access to some dashboards that will allow them to look at outcomes, what kinds of things are they achieving through the programs that they're providing. They can look at that, we can look at that, and we can evaluate that together in terms of what do we expect to see and what are we actually seeing. Evidence-based practices, again, building dashboards to monitor critical outcomes by program and client population. Evidence-based practices are just what they sound like. They're practices that have been reviewed and based on it, the evidence that's been available, they show good outcomes. And if you follow the model fidelity for those programs, you should get an outcome that is consistent with what the research has shown. So we're developing a dashboard to analyze the model fidelity, what kind of services are being provided within those evidence-based practices, and what kind of outcomes are we seeing from those evidence-based practices, so we can monitor the efficacy of those programs, make sure we're getting what we're paying for, and we can see who's being most successful with consumers in what programs. Also, allowing us to identify teams and providers that are most successful within the various programs and with what kind of client populations. And then finally, reducing the manual effort to create the financial status reports. And so we're automating and simplifying that process as much as possible. So we're moving from antiquated spreadsheet models to more automatic models so that we can get faster and more efficient data to the board and to the state. And then on slide 25, this is basically a measure of where we feel like we are in various areas that we're currently looking at. Most of our areas were green. A couple of areas we have the yellow caution light out that we know we have to pay more attention to that and try to look at the areas there that we want to try to impact positively. So we're keeping an eye on this stoplight kind of chart so that we know where we're at with regard to these various projects and elements of the project so that we can try to hopefully have these all green by the end of the contract. And then finally, by the fourth quarter of the project, AFIA is estimating, and again, this is from the original proposal, that the total fees will accumulate approximately $364,000, and that we'd be able to demonstrate clear quarter-to-quarter improvements tied directly to the joint efforts of CMH and to AFIA. I think we're at that point now where we can see quarter-to-quarter gains, and that will continue to get better, I think, as the project goes on. As far as the overall estimate of total fees, if based on what we have been seeing, as we talked about for the first 3 quarters, as the invoices come in, if they stay consistent, we'll come in under that $364,000 number, which would be a positive thing. Again, this contract is up at the end of May, and we have asked AFIA to provide us with a proposal to continue the project with board's approval in order to kind of wrap up some of the things that we have in mind for the data warehouse and make sure that we really get all the things that we are hoping to get out of the project. The AFIA leadership is putting together a proposal that we can have available probably next month that we can come in and look at. It will come in less than the last proposal, and in talking with the staff that manages the grants, it looks like we have about another $75,000 from a technology grant that will be able to contribute to any continuation of the project. But that's for next month. We'll bring that for the board's review at that point in time. All right, questions?
Thank you, Jim.
I do have a question.
Hold on. Kathy?
Thank you, Mr. Chair. Through the chair to Jim. For just a general thing about the hospitalizations, we're talking behavioral health?
Yes.
Hospitalization?
Yeah, strictly behavioral health, yeah. Yep.
So it would be in a hospital that has that department or a hospital that just specializes in
Correct.
behavioral health? If they go in for, sometimes there might be 2 needs, a medical need
Correct.
brought on by behavior or vice versa, either way. Do we have to pay for the medical part of that?
No, we don't.
Okay,
No, the
but
medical.
are they billed concurrently, or is one take over? So if there's medical needs and behavioral needs at the same time, would both be billed?
Both we would be billed, but to separate payers.
But yes, okay.
Yep.
And then more general about the AFIA part, what's the goal in the end with this, that we would be able to, our own staff would be able to use this? Or is this something that we always have to have AFIA people with it, working on it?
AFIA will have to host it. It's a technology platform that would need to be hosted by them. However, we can access it and gather data for management use. I brought just a copy of a dashboard that we pulled yesterday in looking at some issues and trying to answer some questions. And for a real life example, we were discussing a face-to-face pre-screening project, and we were trying to anticipate the volume that we could anticipate if we were going to do face-to-face pre-screenings for inpatient hospitalizations. And 6 months ago, 8 months ago, that would have been, all right, let's go ask the report folks if they can generate a number for us or by month of how many requests for inpatient hospitalization. We were talking about children at the time. How many have we done for children over the last 5 months? that would have been at least a several-day report. We were able to pull it up in 30 seconds and have that information available at our fingertips at the meeting so we could make some decisions about, is that something we can do internally? Is that something we have to maybe reach outside to get some additional capacity in order to do that? So those kinds of things we can do internally, and we'll be able to pull that. FIA will continue to host the project, and if we wanted things, say we found another dashboard element that we said, hey, you know what, this would be great, then we could talk to them about perhaps doing some additional development work. But at the point that we're done, we want to be able to pull that information locally and internally and have access to that information with them just doing the hosting piece of it.
Okay, just one follow-up. Well, at the point at which we're done, you don't mean done using this platform, it would be just having all the data that we need in there?
Correct, once
to
it's
make-
fully developed, where all the data is available via the dashboard process.
Sure, and then there could always be new ideas that come up that
Always,
we need their help. All right, thank you. Thank you very much for the report.
Selena had a quick point of information for something Kathy said.
You cannot bill the medical side and the behavioral health side at the exact same time in Michigan because we're a carve-out. And so what happens is that in an inpatient psychiatric admission, it's an all-inclusive per day per diem. So whatever services you provide that consumer at that particular day comes out of that one lump fee for the day. Now, if a patient presents medical, then you would move them to a medical floor and then you would flip it over to the medical side. The only way that you can kind of do a caveat of that is, let's say that they're on a psychiatric unit and they need a procedure, you would have to get an authorization from the medical side to do it, and that very rarely ever happens. Yeah.
Ryan?
Thank you for the presentation. It was above my IQ level. And above my pay grade. Yeah, do you have any kind, first of all, could you send me all the material on the Avia proposal project that you've sent to the board already? And do you have any kind of executive summary written without acronyms and like at a 6th grade reading level? What's that? Yeah, I think, well, Dave provided us with a glossary and. Yeah, well, thank you.
Yep. Nick?
Yeah, Jim, two things. First off, I want to congratulate you on an excellent report. And I want to, these quarterly reports for new people came about because I was pretty skeptical about the projections of cost savings and maintaining or improving quality of service that Jim had represented this to be likely to bring us, and so I asked that we keep close track of it. And I'm happy, Jim, that you have proved me wrong on both points. So you allied my skepticism. This seems to be a project that is allowing us to use our dollars more efficiently, not denying people hospitalization when they need it. But not spending money on things that aren't necessary, and directing our dollars as efficiently as possible. So I think the project, and I think you'll see, Ryan, when you see the whole thing, is doing what it was intended to do. I didn't think it was going to, but I'm glad I was wrong, and thank you for the report.
Thanks, Nick.
Jim, one quick question for you on slide, I guess it's 25, the last one with the traffic light.
Yes.
The targets, are those self-imposed targets? Are those state targets? Best practice targets?
Okay.
I think there are targets, but
I think they are,
okay.
although if there's a recidivism one, it's probably the state target.
Okay. I know, I picked one of the very last ones.
The service within 14 days of intake, that's a state target. The rest of them are all local.
Okay.
Yep.
Thank you, Jim. Any other questions or comments for Jim? And if you look over the presentation over the next couple days and have more, I know he'd be happy to answer them for you.
Feel free.
All right, we have a motion and support to receive and file. All in favor signify by saying aye. Aye. All opposed? It has been received and filed. Thank you, Jim. Appreciate the report. Next is item 6, resolutions. There are none. We move on to number 7, other agenda items. I have something real quick. In front of you, Lynn passed around a resolution from the Board of Commissioners that was passed middle of March. I wanted to wait to present this till this meeting because we have the new board members here, and it pertains to basically the rules that the Board of Commissioners places on their boards, commissions that they appoint to. There have not been changes since 2011, and I chaired a work group with some staff and some other commissioners to make some minor changes, one of them being an attendance policy. You have to attend a minimum of 50% of the meetings. If not, commissioners can remove you. Also, if you are convicted of a felony while serving on this board, you can be removed by a vote of the board as well. And also, it basically updated the rules to where we use the agenda management system, which is the same one we use at the Board of Commissioners, so we're all on the same page. So if you have any questions when you look it over, feel free to ask me, shoot me an email, whatever you need to do, but I wanted to update you all on that so you're all aware. Any other items from any other board members before I turn it over to Dave? All right, Dave, anything, something?
I think Jim covered everything on AFIA and Randy covered the rest. So I'll have a full report at the board meeting. Thank you.
And you're at the Board of Commissioners meeting today?
I was at the Board of Commissioners meeting earlier today. I was there at the podium. I was on the agenda simply for the updated budget that was approved through this body. I gave a very brief update on the additional revenue that had come over the 3.4 million that resulted in our revised budget. They didn't have any questions, and I was able to depart quickly and easily. Thank you.
Thank you. Linda?
I have a question. The 3.4 million, what, can you refresh my memory on what that just came over, or what?
Actually have the report that I gave to the
Okay.
Board of Commissioners.
I mean, we got money. Tell us about it. If we got
Well,
money.
this was presented earlier, but the 3.4, there was 1.4 million that was from a performance-based improvement project. I believe that was specific, Jim, to the My Health Link, the 1.4. There was a withhold of a 0.75%, and if you hit the performance indicator, which we did, they allow you to get your money back. Mm-hmm. And that came through after the budget had been approved last year. There was a $1 million legislative grant and another $1 million that was a result of the changes to the Medicaid and Healthy Michigan rates.
So this is just new from the budget, not from the last time we met. Okay.
No, it's not, yeah. It was new to the commissioners.
I'm holding a good thought for you there.
No other good news, sorry.
And I have one other question of you. We had an email from Barb about you're trying to set a date. Has that been decided upon yet?
Not yet.
Okay.
But
okay.
we're narrowing it down.
Thanks.
Anyone else with any other items? We do have, 2 meetings on April 15th? We may have 3 meetings on April 15th. Not a personnel, a nominating, and a potential full board. Okay. Starting at 7:30. We're all on various committees, so you may be on one and not the other. You may be on all 3. So I guess Nixon, yeah. All right. Seeing no other agenda items, I'll go to item 8, hearing of the public. Anybody from the public wishing to speak? Anybody from the public? Everybody's looking at each other saying, no, let's go. Okay, we will close hearing of the public. Item 9, adjournment. I'll take a motion to adjourn. Motion from Nick, support from everybody. All in favor signify by saying aye. Aye. We are adjourned. Thank you, everyone.